We're looking at an 80-year-old male, history of hypertension, CHF, and type 2 diabetes. Has a history of falls, and about 10 years ago, he had a, quote, brain bleed from a fall. It's unclear exactly what transpired during his course of treatment, but he spent 3 weeks in hospitalization and rehab before he was discharged to home. His medications include a daily aspirin. He's retired and he lives alone. So lock that in, because this is going to be a little question and answer here with you guys. I'm going to ask for your opinion here in a minute. Okay, this is an EKG that you obtain. This gentleman is in your clinic, and this is an EKG that you obtain. And what do you guys think of this EKG when you look at it? Good call. Yes, he does. So right here you see the little green pacer spikes that are marked on there. Okay. Anything else stick out there? We'll stick with that. Okay. Again, he's in your clinic. Okay. He's asymptomatic, and he's actually diagnosed with permanent non-valvular AFib. So, with that in mind, let's go back to this EKG. How do you know? You look at this. What's sort of the hallmark of AFib? I always think, yeah, irregularly irregular is sort of the classic description of AFib. Well, he's about as regular as it gets right here, right? Because he's paced. So is he in AFib? What do you think? So he actually, his atria are fibrillating still. Yeah, so it's not something you typically think of with AFib if you don't see the irregularly irregular heart rhythm. So in this particular case, he still does need some treatment for AFib. So he's not anticoagulated. He has AFib even though he has a paced rhythm. He has a history of labile INRs. So in the past when he's taking Coumadin, he is in therapeutic range less than 60% of the time. So with that in mind, what do you think we need to do for treatment with this guy? What type of treatment might you, I'll let you, this is sort of something to think about as we go through here. What kind of treatment would you be giving this guy? Talk about some AFib facts. So estimated 2.7 to 6.1 million people in the U.S. have AFib. And this is data from the CDC. About 9% of people over 65 years old have AFib. And this causes more than 750,000 hospitalizations per year and contributes to about 130,000 deaths per year. So you don't typically think of AFib directly causing death. At least I haven't until really getting into cardiology. But this shows that that's very, very prevalent. Okay, AFib in the United States is becoming more prevalent as our population ages and people are living longer. We see this. So here we are, 2015, right there in about the 6 million range. This is going to continue to increase over the next 35 years, according to this graph here in this research. Okay, so let's talk about what atrial fibrillation is. And I think to start with that, we need to talk about the cardiac conduction cycle. So typically, as you guys know, rhythm is generated in the SA node that propagates through the atria down to the AV node. The AV bundle continues down through the septum of the Purkinje fibers, and that creates our typical EKG that we normally see, right there on the top. So normal sinus rhythm is what we call that. P waves followed by QRS. With AFib, there's not going to be a discernible P wave, and you're having multiple sites in the atria that may try to begin its own rhythm, leading to your traditional irregularly irregular rhythm. This is AFib with rapid ventricular response. Depending on the textbook that you look at, this is typically thought of as AFib with a rate above about 130. That varies a little bit with definition in the textbook you're looking at. Paroxysmal atrial fibrillation. So this is defined as AFib that terminates spontaneously within 7 days. And it would also include episodes that in less than 48 hours are electrically or pharmacologically converted. Persistent AFib, AFib that lasts for greater than 7 days or greater than 40 hours and then is cardioverted, electrically or pharmacologically. Long-standing persistent AFib, AFib that lasts for greater than a year. And then permanent AFib where there's basically a medical decision that's been made to not pursue trying to convert that rhythm back to a sinus rhythm anymore. Risk factors and prevention. As we get older, AFib becomes more prevalent. So that by the time you're in your 80s, for instance, the chance of having AFib is about 1 in 5 people. About 1 in 5 people in their 80s will have AFib. Back to that CDC statistic, folks 65 and older have about a 9% chance of having AFib. So that likelihood of having AFib increases with age. History of hypertension, heart diseases, valve disease, prior MI, heavy alcohol use, family history of AFib, sleep apnea, and other chronic conditions like hyperthyroidism, diabetes, asthma. Most common complication after heart surgery. Symptoms. Some people have no symptoms. In fact, a lot of people have no symptoms. And that's a little bit tough sometimes with paroxysmal AFib because somebody may be in AFib for a good portion of their life. They go in, they get an EKG, and maybe the EKG does not identify that they're in AFib. And they don't recognize themselves that there's any change in their rhythm. So a lot of times people are first identified as having AFib when they have a stroke. And that's an unfortunate situation. Common symptoms, again, the irregularly irregular heart rate and rhythm. Sometimes as a rapid heart rate, lightheadedness, fatigue and weakness, shortness of breath, and sometimes chest pain. Okay, so let's go back to our guy, our 80-year-old guy, asymptomatic, permanent AFib. This is non-valvular AFib. So non-valvular we define as not relating essentially to the mitral valve. So no rheumatic mitral stenosis, no mitral valve repair, and no surgical mitral valve replacement. So he made those requirements for non-valvular AFib if he doesn't have any issues with his mitral valve. Then we look at his risk factors. And he has CHF, hypertension, he's over 75 years old, and a history of diabetes. And so we have a risk scale that we use called the CHADS-VASc scale. I'm going to go into that here in a minute. But if we add up those risk factors, that gives him a CHADS-2-VASc score of 5. We also look at something called a Hasbled score. Hypertension, as we mentioned before, he has labile INRs with anticoagulants. He's over 65, and he also has concomitant aspirin use. So we call that a Has-Bled score of 4. He's currently not anticoagulated. So we look at the CHA2DS2-VASc score. This is what we use to help figure out what the likelihood of somebody is to have a clot that would cause a stroke if they have AFib and are not anticoagulated. So over here on the left is the CHA2DS2-VASc score. We look at congestive heart failure or left ventricular dysfunction, which he has. Hypertension, which he has. He's over 75, which is actually 2 points. He has diabetes, that's another point. So that's 1, 2, 3, 4, 5 points there. He had a brain bleed, but that's not, we're talking about stroke from like a thromboembolic stroke in this instance. No history of vascular disease. He's over this age bracket, so that doesn't count, and he's not female. Okay, so he has a CHA2DS2-VASc score of 5. Come over here and look at CHA2DS2-VASc score of 5, and he has 7.2 to 10% annual risk for having a stroke. 2 different studies, large studies. That's why the range of numbers there. Yes, please.
Does obesity have a factor? Is risk factor?
Well, it's not in the CHA2DS2-VASc score, but certainly you can think of other comorbidities and that.
Those parts.
I would believe so. I'm going to ask Dr. Spoon if he has.
I think, you know, obesity portends metabolic syndrome, which would increase the chance of diabetes and hypertension and all those things. So while it's not specifically parsed out in this, it certainly plays a role.
Has-Bled score. So this is one that seems like folks are less familiar with. The Has-Bled score evaluates likelihood of a bleed. It's not quite as specific as the CHA2DS2-VASc score is, but if we look at risk factors here, hypertension, abnormal renal or liver function. If you have abnormal renal function, that's 1 point. If you have abnormal liver function, that's the second point. History of stroke, bleeding tendency or predisposition, labile INR, age over 65, and then concomitant aspirin or NSAIDs or alcohol. So we look at this gentleman here. He has hypertension, labile INR, he's over 65, and he also takes aspirin. And so he has what we say has a score of 4. And with this risk scale, we're looking at if somebody has a Has-Bled score of 3 or greater, we consider them to have a high risk of bleeding if they're on an anticoagulant, and a fairly high likelihood of them having some major bleeding episode at some point in their life while on that anticoagulant. Okay, so we go back to our case study. It's a gentleman who has a 7 to 10% annual risk for stroke, and that's additive. You know, if he has let's say he has a 10%, or so let's say he has, let's go with the lower number. Let's say he has a 7% annual risk for stroke. If he's not anticoagulated, and he's not anticoagulated currently, and let's say over the next 5 years, what's his risk of having a stroke if he continues to be not anticoagulated? 7 times 5, 35% chance of having a stroke if we look at the statistics for him of having a stroke over the next 5 years. So could he not have a stroke? Absolutely. But, you know, a lot of times we look at risk-benefit in medicine, and it's a pretty high risk. But he's a fall risk. He's a high bleeding risk with the Has-Bled of 4. He lives at home alone. He's had a prior brain bleed from a fall. So what do you guys think? Should this guy be anticoagulated? Probably. Any other thoughts on this? Thank you. Okay. So we're going to talk a little bit about treatments now, some new options, but we're going to also cover what is currently what has been done. So obviously warfarin is the medication that's been used for a long time for anticoagulation here, and then novel oral anticoagulants, NOACs or DOACs, as are sometimes referred. And then there's a fairly new treatment modality in which we occlude the left atrial appendage. And we do that because the left atrial appendage, as Dr. Spoon is going to talk about here now, is really the culprit for most of these people who have AFib with having strokes. Okay.
Well, thank you, Steve, and we really appreciate the opportunity to speak today. It's an important topic. Atrial fibrillation we'll all see in our patients, as Steve has outlined, and we are all faced with patients sitting in this rock in a hard place where we don't know what to do. They've got a very high risk of an embolic stroke, but they're also at very high risk of bleeding. And so we're going to talk about a new therapy today. We're going to talk a little bit about the data behind the therapy. We'll talk about the procedure itself, and then we can move forward there with any questions. Please feel to interrupt and ask questions anytime, but we're going to move ahead with that. And so, as Steve mentioned, this is the cardiac anatomy, and it's the heart, and it's cut in a long axis. See a left ventricle here, a right ventricle here. The aortic valve would sit here, blood's pumped out the aorta. Here's the mitral valve, and behind the mitral valve up in this area is the left atrium. Sticking off of the left atrium is a vestigial appendage called the left atrial appendage. And there is a right atrial appendage, but it's not nearly as important. It's not nearly as large. But the left atrial appendage, and you can see this little tube, this is the circumflex coronary artery. And so we'll talk a little bit about why it's important. You guys are going to know more about the left atrial appendage than you ever wanted to at the end of this talk. So this is a TEE, a transesophageal echocardiogram that shows, it's the best way to visualize the left atrial appendage. So if you do just a regular transthoracic appendage due to where the appendage, or do a regular transthoracic echocardiogram, due to where the left atrial appendage sits, you're not going to see it well. It's a posterior structure. So it's impossible to completely rule out a thrombus in there, identify the anatomy just from a surface echo. And so that's where the TEE comes in and is very important. Sits behind the heart and visualizes the appendage very well. So you can see here, and these don't move, but we will have some that do later on. And you can see the appendage is outlined here. And this one, we're going to get into some nomenclature about the appendage in a minute. And whoever named it was always obviously very hungry, because a lot of food shapes came up in here. But this is one that's more of a windsock shape. It's one of the few that isn't termed a food. And you can see in here this density, and this density is a thrombus, actually. And so in the appendage, you can see the density is moving as they are taking the TEE. You can see the appendage, the thrombus is coming out of the appendage here. So it used to be sitting down here, it's coming out of the appendage. It is gone now, and the most likely area where the appendage goes is back into that left ventricle, out the aortic valve, and into the brain. And seeing lots of people who've had strokes, seeing lots of people who are at risk of stroke, a lot of my patients state point blank they would rather die than have a major stroke. This is a debilitating condition that can take you from a normal, functioning individual living at home to somebody that is institutionalized in a minute. So location of thrombi in the left atrium. So some of these things, this new procedure has allowed us to delve a little bit into more of where do they come from. And you can see the blue lines here, multiple studies that have been collated. And we can see that the vast majority of strokes come from the appendage. Not all of them, but about 91% of strokes start in the left atrial appendage. And so that's key, because identifying where the majority of these are allowed us to create a therapy to potentially reduce them. So as Steve mentioned, we've got different anticoagulants, and we commonly see patients in this rock in a hard place situation. They're somebody that we clearly believe, based upon the guidelines and their risk factors, should be anticoagulated, but boy, we are uncomfortable doing it because of their risk factors of bleeds, and we see them all the time. And up until this point, what we've done is we've given them an aspirin and a prayer, and we've said we hope that things don't go bad, because we've proven time and time again that aspirin does not reduce the risk of stroke in these settings. So there's warfarin, there's the factor Xa inhibitors, which are the NOACs, Xarelto, Eliquis,
endoxaban, very rarely used. The direct thrombin inhibitors, Pradaxa, and then antiplatelets, and this really has no role in embolic stroke prevention. So warfarin, what are the issues? So some patients, low time in the therapeutic range. We've all seen them, and it's difficult. And in Montana, with our unique population, we put these people on anticoagulation, we send them back up to Scobie, Montana, and we never hear about them. And so it is hard to monitor, and the INR clinics do a great job, but it's a little bit out of our control based upon their willingness to follow up. Elevated risk of bleeding, we know, some pretty low compliance with this, very high risk of drug-drug interactions. You've all heard of the patient that gets put on an antibiotic and their INR goes to 15 because of the antibiotic interaction. NOACs, no antidotes. So the nice thing about warfarin is if you have a femoral fracture in a car accident, you're on warfarin, we can give you vitamin K, we can bring you in, we can reverse it. At this point in time, there are no commercially available antidotes for the NOACs. They are developing them. They should be out in commercially available at some point. But what we do basically, if you have a big bleed on a NOAC, is wait. We wait for it to get out of your system. And they are very expensive, and depending on your insurance, they will only cover one, they'll cover two, they might not cover any. We're getting more and more coverage with insurance, but it still is an issue for a lot of our patients. This is, I think, a very interesting slide. This data here surprised me, but when you look at emergency hospitalization for drug events in older U.S. adults from 2007 to 2009, what drugs cause people to come to the ER and be hospitalized? It's warfarin and it's insulins. So those are the two drugs that are very effective. They do what we want them to, but also carry risk. And it is large part due to the tight monitoring they need and the significant patient compliance that they require. So non-valvular atrial fibrillation and stroke prevention. Again, I think these are some very telling statistics. So warfarin right now in our country is the most commonly used. It reduces embolic stroke by 64%. It is severely underutilized. We always find a reason not to put our patients on warfarin. Even after an AFib stroke, only 30 to 7, granted that's a big splay, depending on the study, are anticoagulated. So we're nowhere near putting as many people on anticoagulation as should be. And this here to me is a very important statistic. After 3 years of starting somebody on warfarin, 50% of patients have discontinued their therapy. So as the physician, as the nurse, as the provider, we are in an office, we put somebody on warfarin, we feel great about it, we're reducing their risk, and 3 years later, half of them will have stopped it for some reason. A bleed, they didn't like it, they didn't want to get their INR checked, false information, they didn't think they could eat leafy green vegetables. And what this comes down to is the clinical reality that we face is that vitamin K antagonist, warfarin, only achieves a fraction of its evidence-based potential. So all the studies that say warfarin does a great job implies that patients continue taking their warfarin. And that is a major issue that we have with our patients. And you can see it in every aspect. Patient compliance is difficult. So NOACs versus warfarin, we'll go through this quickly. They've done a lot of studies, RELY, Rocket AF, Aristotle, Engage, AF-TIMI 48, all fancy names of clinical trials that were done. The overall combined effects of these in a meta-analysis in the Lancet shows that NOACs result in a significant decrease in death compared to warfarin. They result in a significant decrease in brain bleed compared to warfarin, and they result in a significant increase in GI bleed compared to warfarin. Again, they're expensive, they don't have an antidote, and since this data in 2014, more and more data trickles out, and not all NOACs are created equal. Eliquis may be better, we've got some other data, but it continues to roll out, and that's the difficulty we have with any new therapy is we may have short-term data, we don't have long-term data, and that's one of the things we'll talk about with the Watchman device itself. So novel oral anticoagulation, discontinuation and bleeding rates. And so rates of discontinue in the study in patients that are monitored closely, about 25% of patients stopped their NOAC for some reason, couldn't afford it, didn't like it, didn't want to do it, bled on it. And then major bleeding events are about 2 to 4% depending. And we have more newer data on this, but roughly about the same. So what are we doing with the left atrial appendage? We know it's implicated in a majority of the strokes, embolic strokes in patients with atrial fibrillation. We know it exists. It serves absolutely no function. And so what do we do and what have we done with it? You can see the heart here, and this auricle here, or this ear, this is the appendage. And so this is the left atrial appendage that sits here. And the heart is actually rotated And so this is behind the heart as it sits in the chest. You can see it here. This is the appendage here. It comes down behind here. And again, there is no known function of the appendage. This is the mitral valve, and this is cut kind of in midsection of the heart. So we're looking from the apex, or the atrium. We're sitting in the atrium. We're looking down the mitral valve into the ventricle, and you can see the appendage coming off of here. And basically what it is a cave. And it's a cave that provides stagnant blood flow. So if you've got blood flowing through this valve, the one thing that we all know about blood is that if it's not flowing, it is clotting. And that's why it's effective. You cut yourself, it pools on the skin, it clots. In atrial fibrillation, there's much slower transit of the blood from the atrium because normally we have concerted atrial contraction that pushes the blood to the ventricle. But in atrial fibrillation, what we have is quivering, and the atrium just look like a bag of worms, and they do this. And so the blood tends to swirl in the atrium, and more importantly, the blood swirls and stays in here, and it's impressive. On TEEs, you can see what's called smoke. It just looks like smoke in the appendage, and it really is just stagnant blood sitting there thickening. And so that is the reason for anticoagulation in atrial fibrillation, is to prevent that from occurring. This is a nice picture. It's the same thing. We're sitting in the atrium. We're looking down in the ventricle. Here's our mitral valve. And this is an autopsy specimen showing a large thrombus residing in the atrium and in the appendix. And this is an issue because the right atrial appendage is not as big of an issue. It's smaller. It's not implicated in much, and it's because we have the lungs as a filter. And so it's systemically, you can get large pulmonary emboli, but a small break off of a clot, we probably don't notice. Here, a small break off of a clot causes a stroke. Left atrial appendage morphologies. And again, I always get a kick out of this because somebody must have been pretty hungry. And so what we have is, what we've learned as we do this is that the appendage is a lot like your fingerprint. Everybody's appendage is pretty darn different. It can have multiple lobes, it can have one lobe, it can be very deep, it can be thin wall, and there's a lot of different things it can have, and that's important for our planning of the procedure. And so we see a cauliflower appendage, we see a chicken wing appendage, we see a windsock appendage, we see a cactus. One of the most, or least common, but most difficult to occlude is a broccoli appendage. We don't show it up here. And again, this just shows some different morphologies. You can see the appendage here. This one is multi-lobed, so you've got even more lobes for clots to form, and you can see how deep this is. And just again, the main point of these two slides is everyone's appendage is wildly different.
So if you don't have, if you have good atrial, how does it look flowing through there?
Yes, much better. You don't get that. You don't get that as nearly as much stasis in that appendage. And so a lot of times stroke and atrial fibrillation has been blamed upon stasis in the atrium. There's also other factors. Machat's-2-Vasc hits on those, so it's risk of stroke. And so hypertension, diabetes, hyperlipidemia, all those type of things make you more likely to have a stroke from a variety of perspectives. So it's, I think, a little simplistic when we explain it that it is purely due to slow flow in the appendage, but that is clearly what we are treating with anticoagulation. And the flow in the appendage is not nearly as slow when your appendage is contracting forcefully. So great question. Same thing here. This is showing an Amplaster device, and we'll talk about this in a minute, but this is the appendage sitting in the atrium. It's got a cave behind it. Here's the orifice of the appendage, and what we do is we occlude it. We block it off. It's as simple as an anatomical closure of this. What happens is that thrombosis over time back there seals off. This will become endothelialized, so it's lined with heart cells, disappears, and what we've done is excluded this appendage from the circulation. So what have they done in the past? Well, surgeons like to do surgery, and what happened is they were all, when we looked at this, the therapies outside of anticoagulation were open heart surgery for the most part and potentially thoracoscopic approach. Excision. Sometimes when surgeons are in there repairing something, they just cut it off and sew over it. Sewing, purse string, stapling, they've got tissue fusion. Atrial clip was something that came up that you could go in thoracoscopically and clip it to do it. So for a long time, we've been using surgical means to try to mitigate the risk of the appendage. Patients don't like thoracotomies or sternotomies. I've learned that in my time. So percutaneous occlusion devices. So this is something that didn't just start out one day. There's been a lot of brain power going to this. There's been a lot of company interest in this. There's a lot of money to be made with devices, and so there's been a lot of things tried. So here's a Watchman.
This is the first FDA-approved device, CMS and FDA-approved, and that's what we're going to talk about today. There's the Amplatzer Cardio Plug. There's the Amplatzer Amulet. This is currently in clinical trials. I've never actually heard of this. This got shut down early on, I believe. There's more of these, a transcatheter patch, a lambrey device, the Lariat device, which we will not talk today. That was FDA approved in kind of a rushed fashion. Had a lot of problems with it. We don't do it because of the technical difficulties of it, and it just doesn't have as good of outcomes, but it is something that is offered. I am not a believer in the Lariat. But you can see that a variety, a host of things have been developed, produced, patented to try to solve this problem percutaneously. So this is the Watchman device, FDA approved, CMS approved, and it's one of the most studied devices in all of device history. And that's important to me because my major thing is show me the data. It sounds great, it looks beautiful, but as physicians, as providers, we really, a lot of things in medicine that have sounded like a good idea don't pan out. And so what I like about the Watchman device is it has been and continues to be a rigorously tested device, having undergone 2 major long-term clinical trials. And so this is what I like about the Watchman device. I feel like our FDA has gone about it the right way to approve this device. So we're going to go through just some patients, some data. This is not meant to overwhelm. The details of this are not significant. We will not get in and parse out the finer details of this, but I just want to show you a couple things. And so this was the first study that was done, and it was a pilot feasibility study in 2007, published in 2009, and it just says, is it going to be feasible to put it in? Is it going to be safe to do it? And does it do some of what we hope it does? And the answer is yes. So intention to treat all stroke. Key implication, confirms role of left atrial appendage in stroke. With the Watchman, the risk of stroke at 1 year, or at 1,000 days, was significantly less than the control. That's all they were looking for, was it safe and did it do it? It met its endpoints. So then what they did is the first large randomized controlled trial, Protect AF. And it's an intention to treat trial. And the goal of this trial, and the wording is important, but the goal of this trial was non-inferiority to warfarin. And so it's a big deal, as someone who's designed clinical trials, it's a big deal in how you power your trials to how you interpret your endpoints. This was designed for non-inferior, saying that the device is not worse than warfarin. Not superior, but non-inferiority. And what we found in this one is 40% lower relative risk in the device group compared to the control group, and that is the warfarin group. The device is superior to the warfarin group for the primary efficacy endpoint of stroke, systemic embolization, cardiovascular unexplained death by the data, but again, it was non-inferior to warfarin. And so that's what they wanted. If we were going to start to spend a bunch of money on a trial and do it, the first thing the FDA wants is it worse than the best standard care? And this was not worse than that. So what they did about long-term Protect AF, so they did the trial and they started a CAP registry, a CAP, Continued Access Registry to Protect AF. So even the trial was done enrolling, they were still collecting data to see how it went longer out. And with longer endpoints at 5 years, the benefit of this compared to warfarin showed that it was probably superior and definitely not inferior. So safety events, and so this is important because what happens is when you're taking warfarin, there's no procedure. And so the question is how risky is it to put this device in? And so when they first started, the risk of a major complication in Protect AF in the first half of the trial and the second half of the trial was dramatically different. The device was altered some, the delivery system was altered some, and we learned a lot about putting it in. So about 10% risk of major complication in the first half, back in the 2007, 2008 range. Second half, it went to 4.8. In the registry, the CAP registry, it went to 4.1. In the next randomized controlled trial, it went to 4.2. Now that they've rolled it out clinically, we're seeing it down in the 2 to 2.5 range. And what we've specifically done in these trials as a field is in Prevail, we didn't give it to all the experienced operators. More than 50% of the operators in this trial were brand new. And that was important to see how do people do rolling this out. And we continue, because of device design, improved technique, reduce the risk, and now it's about 2 to 2.5% of a major adverse effect during the procedure. We've never seen any in our practice. So warfarin cessation rates, high in Watchman patients. This means if we put the device in, does it allow people to get off of warfarin? And one of the things we look for is the seal. And so when we put it in, 45 days later, we do another TEE and we make sure that the appendage is completely sealed, because if there's a big leak, you can imagine it's not doing what we want it to. And in the PROTECT AF, the CAP, and the PREVAIL trial, what we're seeing at 12 months, 99% of people in the most, 99.3, 96, 93, are able to come off their warfarin because there's an appropriate seal of the appendage. Out of all the patients we've done, both that I've done at the Mayo Clinic before I came here and we've done here, we've never had one not sealed. The procedure itself has gotten much better and much simpler due to the delivery devices. So this is a meta-analysis looking at all the different studies, and what we say is it favors Watchman on this side, it favors warfarin on this side. Most everything is either equivalent. Hemorrhagic stroke, you can imagine, dramatically favors Watchman because you're not anticoagulating them. That's the huge thing. There was some sign in a little bit that ischemic stroke was maybe a little bit better in the warfarin, but that hasn't borne out in future ones. And you can see the confidence interval is high. But one of the things I'm going to talk about is where we're applying this, I'm not comparing the device right now to warfarin. I'm comparing the device to nothing, because we're putting it in patients that don't have the option of warfarin currently, and I can promise you that it's dramatically superior to nothing. Bleeding in Watchman, so you can see control, and then the device and the control is warfarin, and so at 7 days, and this is procedural bleeding, and so I think it was important that they parse this out. When we do the procedure, we go in through the femoral vein, and there's a possibility of bleeding. And then after that, in months, we go down here, and the control with warfarin significantly higher, really no difference in bleeding compared to not having anything done. So when we do, again, I think it's just important to hit the high points of the data. This is an extremely well, rigorously designed, studied device. I have no personal interest in this device other than helping patients. The whole thing is I really appreciate how our FDA approved it. You can believe our FDA, sometimes they take too long and everything's approved in Europe sooner, but the way they went about this, I think is very appropriate. So conclusions from another patient-level meta-analysis: in patients with non-valvular AFib, again, at increased risk for stroke or bleeding, who are candidates for chronic anticoagulation, left atrial appendage results in improved rates of hemorrhagic stroke, cardiovascular or unexplained death. For some reason, these patients lived longer. Non-procedural bleeding compared to warfarin. So this is in patients who are candidates for anticoagulation. Observed and expected rates of stroke. So you can see here, expected if we don't do anything, and this is that CHAS-2-VASc score, and this is a score of about 5. Expected if Plavix was used through fall, so just it reduced some, but not dramatically. And observed in an ASAP trial, 1.7, so really, really low. Observed rate of ischemic stroke represents a 77% reduction from the expected event rate. So very impressive data. One of the things we always ask is a procedure, is putting in a device as cost effective as giving somebody a medicine? And it's very important in these healthcare dynamics. And so you can see that it does take some time to cost effectiveness, but people don't or shouldn't stop NOACs or Coumadin. It is a lifelong medication. Your risk of stroke does not go down, it only increases with age. And so you can see, so time to clinical effectiveness, left atrial appendage occlusion versus warfarin, at year 3, you are just as effective and you will become more effective after that. At year 7, if you can have a device in for 7 years, and we don't remove these, so if you can live for 7 years after we put a device in, based upon the quality analysis that people do at $42,000 a year, and that's the standard here, what we have is that at year 7, putting in a device is more cost effective than warfarin itself, and that has to do with the medication is cheap, but the follow-up, the INRs, all of that kind of stuff, all is included in that cost. And so time to dominance. When is the device more effective, less costly than Coumadin? That's at 10 years. When is it more effective, less costly than a NOAC? That's at 5 years based upon all this data. So one of the things that would be said is as we look to maybe potentially roll this out to lower risk patients in the future as the data suggests, If I'm going to put it in somebody that can tolerate Coumadin, who's doing fine on Coumadin, who just doesn't want to be on Coumadin, but is not expected to live for 10 years, well then maybe that's not a great option for them, because it'll take 10 years to see that whole dominance. NOAC less, because NOACs are a lot more expensive than Coumadin. So I think just interesting to keep in mind that in our cost-conscious era, we need to be doing the right thing, but we also need to do it in a cost-effective way. So time to cost effectiveness following stroke reduction and atrial fibrillation, little difficult to see. Both NOACs and left atrial appendage occlusion with the Watchman device were cost effective relative to warfarin, but left atrial appendage was also found to be cost effective and offer better value relative to the NOACs. The results of this analysis should be considered when formulating policy and practice guidelines for stroke prevention in AF. And this is a big part of the reason why this got FDA approved, is it's cost effective, it's safe to put in, and the data is excellent on it. So here again is a picture. This is the Watchman device in the appendage. What I want to show you now, this is a video that shows the procedure, and I'll talk you through it. So this is our catheter. This is the device, how it comes out and is deployed. So we do this through a femoral vein approach. We do it under general anesthesia because we're doing a TEE as well during the time, so it's guided by that. We go in with a sheath in the leg. We go up through the femoral vein. We go up into the right atrium first, and you can see us up in here. It'll pop up here. I promise it will. So we bring our sheath up into here. We perform what's called a transeptal puncture. We cross the atrial septum here with a needle, very carefully. We go into the left atrium. We put a wire into the left superior pulmonary vein. We bring our catheter in here, and that makes our wire very safe. Get our wire out, we put a pigtail in. What the pigtail does is it's a shock absorber, and it allows us to not have this stiff end against anything. This is a broccoli, the ominous broccoli. Here's our chicken wing. Windsock, you always like seeing windsock. It's wide and it's deep, so our device fits well. So we bring the pigtail in here. We then slide our catheter over. The important part is this structure is really thin. It's paper thin. You can see a light through it if you illuminate it. We measure the size we think we need. It's available in a variety of sizes. We want to be aligned at the left atrial appendage ostium. We don't want to be too deep. We don't want to be too far out. We want to be exactly there. We get a little pop of contrast that illuminates this for us. Kind of know where we want to be. We've sized our device on TEE. We've checked it with this. Get our pigtail out. Hold the breathing. So they hold the breathing, so there's no breathing during this for a couple minutes. We put this in, and then we pull the sheath back. We do not push this out. The device is pulled back. The nitinol springs open, and we seat our device there. There's little hooks here, and there's compression. We oversize the device so it's bigger, and it's held into place. We test it by pulling on it, and we pull pretty vigorously. We make sure that there's a good seal here. We look under ultrasound to make sure we like it. We release it, and it's securely seated in the appendage. Over time, our body will line it with its own endothelial cells. It becomes invisible to the body, and it has occluded that appendage completely. So that's the procedure. That is the procedure in a nutshell. This is us in the cath lab. We've got a great team, a big team. This is one of the ultimate team sports. We've got Steve as our Watchman coordinator, and we couldn't do this without him. This is Dr. Todd Maddox, one of our interventionists. This is Dr. Simone Musco, one of our electrophysiologists. This is myself right here. We've got techs. We've got echocardiographer. We've got an anesthesiologist. So anytime we're doing this procedure, there are 5 physicians in the room. 1, 2, 3, 4, 5. And we do it just for safety. The procedure is quick. We know the anatomy. We go in, and so probably 30 to 45 minutes is how long it's taking us. Patient stays overnight in the hospital for 1 night, gets an ultrasound just on the chest the next morning to make sure there's no pericardial effusion or anything. They go home the next morning with really no limitations. That actually is my sister. So she's a non-invasive cardiologist at the IHI as well, and so unfortunately, if you want to have the device in, you're going to have to put up with her for a little bit. She's my big sister, and she always used to hit me and run and hide behind my mom. And so here's a picture, and it should be live. So this is just the appendage. We look at it in a variety of different views, and so 45, 90, 0, 130, because you don't get a sense of the appendage just from one view. This is at 90 about, and you can see here, and so you can see how deep this is. This is a very nice appendage to occlude. We can get a big device in here. We can seat it deeply, and so the thing we want is we want more depth than width. If you get too much width and not as much depth, you can imagine how that's not going to plug very well. And so we haven't had anybody's appendage that we've seen that we've tried to plug that we couldn't. There's a variety of things we can do to do it, but we have a good sense going into the procedure of what we're going to deal with based upon the anatomy of the device, anatomy of the procedure. This is another view. This is the device sealing, and so you can see it's still hooked to the catheter. So what we do is we put it in there, we deploy it, but we leave it on a tether. If we don't like it, we recapture it and we come in with a different device. And so there's a lot of, so we take great care, and this actually probably takes the longest time of the procedure. We put it in there and then we sit and we have to be quiet while my sister really evaluates how well this device fits. Do we like the amount of compression? Do we like how there's no flow around there? Is it too big? Is it too small? And once we get the okay, we pull on it, we look, there's all this criteria that we go through before we release it, then we release the device and it's in there. This again is another picture, and you can see the mitral valve, the left ventricle, the appendage, and this is our occlusion device here sitting here. This is a 3D TEE, and so she gets great imaging views, and this is looking at it, and this is the device well seated, looking at the appendage. It's like one of those anatomical shots that you got. We're looking at the face of the device sitting in the appendage. So this is endothelialization. This is in a pig model, and what we see here is the device is in. It's well endothelialized. You can't even see the device anymore because it's covered with atrial cells. Here's it's actually a canine model, and then human pathology. So dog model, you can see how well it is, and then this is somebody that died of other cause. They took it out, and you can just see how well it's endothelialized. So what are we doing with our program right now? What we're doing is I can conclusively say that this device is far superior to nothing. That goes without saying. And so we have a lot of patients, and you would be surprised at how many patients, and maybe not surprised, they sit in there and their primary doctor wrings their hands about, I really want to anticoagulate this patient, but they fall a lot, they've had a bleed, exactly what Steve outlined. And those are really good candidates for this device, because if the option is nothing and hoping they don't have a stroke, this is far superior and at least equivalent to warfarin. The issue that I have right now is I don't want to put this in everyone because I want more data to come out in the long term. And the patients that I'm a little hesitant to do it in are, and the FDA allows us to, the FDA indications for this are very broad, is a 55-year-old man who just doesn't like being on warfarin. And so that is, it's somebody we could put it in. We would have a long discussion with the patient. It doesn't mean we would hold off and not do this, but that's where I like the registry data, because the longer these devices in, we'll see. And I always tell some patients, I was like, we don't know, at 22 years this device might catch fire. I don't think it will, but we don't have the data, and I like data. And so we've got data, 5, 10-year data in Europe, but if we're looking at somebody that's going to live 5 or 10 years or 15 years, we've got great data. But if we've got somebody that has to exist with this device for 40 years and they're tolerating Coumadin well, I don't know that we have all the data I would like to put it in. So with our program, we are not willy-nilly offering this to everyone. It doesn't mean we're excluding people or keeping this technology safe, but we do a very cautious way, and our approach is we want the highest risk patients first. We want to do this. We want to be great at it. And then over time, we'll let the data sort itself out, and we'll expand it to lower populations. So inclusion criteria, non-valvular AFib. AFib in the presence of absence of rheumatic stenosis, mechanical or mitral valve repair, as Steve mentioned. CHADS2 VASC of greater than 3, or a CHADS2 of greater than 2. So if somebody comes in and their CHADS2 VASC is 1 or 2, by FDA guidelines we can't offer it. Their stroke risk is not high enough to warrant this. Suitable for short-term warfarin. Why is that important, and how do I think that's going to change? After we put this device in, we want people on warfarin for 45 days. And the reason is we want to give the device time to endothelialize. So it's a big issue. If somebody has had a major stroke or a bleed or something, GI bleeds, and they've been off warfarin, we tell them we're going to put this device in, but we'd sure like you to be on warfarin for 45 days. That is changing, and that was the FDA mandate initially, because in the practicality of scheduling and doing these randomized controlled trials, the death of this device was going to be clots. If they had more strokes with this device than warfarin, it was done. So they were extra cautious in ensuring that the device didn't have any clots form on it and just overlap so that they didn't have a stroke not related to this while it was done. And so in Europe now, they're already not putting people on warfarin. I've got a lot of colleagues across the country that say, boy, if they're this high risk, we're not going to do the 45 days of warfarin. We'll just do Plavix and aspirin. And the Plavix and aspirin are just to prevent anything from forming on the face of that device until it's re-endothelialized. So there's ways we can do it. We've done our first couple where we've decided not to put them on warfarin because they were such bleeding risk, 7 or 8 bleeds and major things. And so we've done our first couple. And further we get out, we'll be much more comfortable doing more. Appropriate rationale to think non-pharmacologic alternative to warfarin. And this is what gives us, it was very interesting to see how CMS and the FDA were going to approve this for. Was it going to only be approved for people that couldn't tolerate warfarin? Was it not going to be approved? And they came out with a very broad approval. Has bled of greater than 3, they're at risk of bleeding. Labile INRs. Medical condition, occupation, or lifestyle placing the patient at risk for bleeding or trauma. It's as simple as if the patient doesn't like warfarin for one reason or not, they're a candidate for this occlusion device. And I'm a little worried about putting it in just because of the reasons we talked about, but the FDA has been very broad in who we can apply this to. Exclusion criteria, we don't put it in valvular AFib. If they've got an intracardiac thrombus, we don't put it in there because we can, with our device, as you saw, we're sticking a tube in there, we can dislodge it. ASD or PFO repair or previous closure, if their left atrial appendage anatomy won't fit one. And we know this for the most part because we do a pre-procedural TEE. So anyone that's looking to have this done as part of the workup, they get a TEE done to evaluate their appendage to make sure it accommodates it and make sure there's no thrombus. Contraindications to warfarin, aspirin, or clopidogrel because of what we talked about. Any customary contraindications to catheterization procedure and known hypersensitivity to device. I can't imagine that exists. It's nitinol at the very end. You've got this PTFE covering on it. So this is our Watchman team. Dr. Musco, EP, electrophysiology. Jocelyn Spoon, she's our imaging. World-class imager, structural imaging. Todd Maddox is a wonderful interventional cardiologist who started a lot of the structural stuff we do at St. Patrick's Hospital. Steve Shepro, world-class PA, and just a handsome man as well. And then me back here in the corner. And so that's basically it. We've gone through a little bit of atrial fibrillation. We've talked about the risks, the benefits, why we treat atrial fibrillation. We've talked about the normal ways to do it, and then a new device. We are the first center in Montana and in the region to offer this. Done a significant amount of these at the Mayo Clinic before I moved home. I'm a Missoula kid, and I spent the last 15 years in Rochester, Minnesota. And I not really jokingly say the reason we moved back was because all my kids started to develop long O's. They started to sound like Minnesotans, so we had to get them home. And so we moved back and so brought some of this. We're doing it. What we're doing is about 3 cases every 3 weeks. And so we're being judicious at how we put this out. We've got more patients than we can do this on, but if there's anything we can ever do for anybody, we'd love to talk to the patient. And again, our goal is not to convince people to do this. We just think it's really important that with the new technology, people know what's available. And that's the key to me, because if we don't know, they can't make educated decisions. And up until recently, they had warfarin or a NOAC or aspirin and a prayer, and the aspirin doesn't do anything. And so we now have another tool in our toolbox. And it's not for everybody, but I think it's important that patients know it exists because it is a really good alternative for some. So we really appreciate your time. Thank you for coming early on a Friday, and if there's anything we can do, we're happy to do it. Yes?
You showed how the heart covers over the front of the valve, kind of, or the device facing into the heart. What happens to the cavity where the appendage was?
Yeah, and so over time, because we'll occlude it with blood in there, the blood will clot, the blood will form, and then it will, so long-term clotted blood forms basically a fibrinous solid product that can't go anywhere.
And so basically what it is, and that's why we look for the leak. We make sure we have great seal. So because in reality, we don't care what happens behind there, but it basically, it walls it off, and over time, that clot basically turns into a tissue. It basically just gets fibrin deposited through it. And so you had an open windsock, and now you've got a completely closed solid structure. It's a great question. All right. Thank you.